My name is Michael Lewis. Here at Healthmonics, I will be your MIPS specialist walking you through our presentation today. Sorry for providing the wrong screen share there for a minute. So as we keep going, let's jump over to our next screen. So you'll see on the GoToWebinar widget on the right-hand side, you'll see the ability for you to ask questions, as well as your ability to take a look at the handouts. I've included 5 handouts. The last one that says MIPSPRO 2021 is the webinar slide deck that you can use for future reference. Ask as many questions as you can. There is a lot of information on this webinar, and I expect it to go for the full hour. If I do not have the opportunity to answer your questions, I will get back to you in a timely fashion with the answers. So today we're going to review 3 things. We're going to go over 1, the 2021 MIPS changes and their effect on you. 2, the tips on how to maximize your return on investment. And 3, how Healthmonics will work for you. And a quick answer, yes, this will be recorded, and I will send the recording as well as the slide deck out to everyone this afternoon. So what were CMS's objectives for 2021 reporting? And you'll see if you've been part of our previous presentations, there is a lot of familiar information, but it is a good time to review the information. There are some new tips and tricks we'll get to, but I did want to share that if you've been part of our final 2021 MIPS final, that you may have seen some of this information before. So CMS's objectives were to minimize changes, to reduce the burden on providers digging out of COVID-19. They basically didn't want to make that many changes going into this year. But in turn, they still wanted to keep the momentum moving for the quality payment program, knowing that it's not going anywhere. It's been successful in their eyes, and they want to keep it moving forward. They want to make it easier for providers like you to not only participate in MIPS, but they want you to move forward into other alternative payment models, APMs, and we'll get into a little bit of that during this presentation. And in the end, they also wanted to begin to incorporate some additional reporting options. You'll see that there are 3 or 4 new reporting options in 2021, as well as the growth of them moving forward into 2022 and beyond. The steps have already taken place to get them going. So some things that are staying the same as 2020. The eligibility hasn't changed. You still need to have $90,000 plus in Medicare Part B charges with 200 Medicare Part B patients and 200 covered professional services. There is rumblings that may change in the future. I wouldn't expect anything for 2022, but they do believe that they may lower that $90,000 to have more providers engaged in the program. Eligible clinician types are still the same. So if you're eligible in 2019 and 2020, you'll still be eligible in 2021. They are going to add, or at least rumblings once again, is that clinical social workers are on the docket to be added in the near future, as they've already implemented changes in certain measures over the last year plus to include them. Exceptional performance threshold is staying the same at 85. That's where you can start getting your max incentive area. Quality data completeness is staying at 70%. I do expect that to move up in the near future as well, as they want to get a full picture of what is going on in the patient population. The opt-in policy is still the same. So if you meet any one of the 3, at least one of the 3 eligibility low volume thresholds, you can opt in for reporting in 2021, the same as you could have in the previous couple of years. So MIPS 2021, some of the changes that are here is that quality is going from 45 to 40%, while IA and PI are staying the same. and that's promoting interoperability and improvement activities. And the cost is moving up to 20%. And we'll go over cost a little more detail towards the end of the presentation, but the cost is also by law moving to 30% in 2022, even with your quality score. So what is the most impactful change? After looking at the 2,000 plus pages of the final rule, the most impactful change that we'll have on our users as well as others is that the minimum threshold to avoid the penalty has gone from 45 to 60%. As we'll go over multiple times during this meeting, during this webinar, is that 60% is the threshold now, where there really is no easy trick or steps to take to avoid the penalty. You really need to start paying attention, if you hadn't started in January, right now to your MIPS scores so that you can get moving forward. And as you can see, it's not stopping now. By 2022, CMS is saying that the program needs to be budget neutral. And by making it budget neutral, it's meaning that there are as many people paying into the program through penalties that are getting incentives. So with that being the case, by 2022, they are estimating that you will need 74 plus points to get to avoid the penalty. So the anticipated revenue impact, you can see there is a change, obviously, like we discussed, from 2020 to 2021. Here you can see that greater than 85 points, you will be eligible for the exceptional performance bonus. And from 60 to 85 points, you'll avoid the penalty, plus be eligible for the additional payment, but not the exceptional performance. At 60, you're going to get a budget neutral, so you're going to get your neutral payment, you'll have a 0. And then from 15 points to 60 points, you'll have a negative payment adjustment that is scaled from 0 all the way down to negative 9%. And anybody that doesn't score at least 15 points will automatically get a 9% payment adjustment, negative 9% payment adjustment. So what should you do today? This works for everybody from the individual solo provider all the way to the large organizations with thousands of providers. So knowing your strategy, is it going to just be penalty avoidance? We're going to cover how to do penalty avoidance later on. As I said, there is no real trick to the trade, but there are steps that you can take right now that help you get to avoid the penalty. Or are you going for an incentive? The incentive dollars are out there this year, as we'll see in a little bit, to go get a larger incentive and really get a return on investment from the work that you've been doing in MIPS for the last couple of years. And know what categories you will get scored on. That's really important. There are 4 categories, as I was showing on the previous screen. However, a lot of providers can be exempt from 1, if not 2 of those categories, and knowing what you need to report on is extremely important. Maximize what you get out of your quality measures. You want to choose the right measures. We're going to spend a little bit of time during this presentation going over what are the right measures. Should you be reporting on the same ones year after year, like the pneumonia and the flu and the medication list? Should you be looking at newer measures that are coming out right now? What's your specialty? Are there specialty measures that can really help you? Increase measure capture by creating workflows within your practice. That's really important. My years of consulting in this industry and working in individual specialty provider practices has led me to really believe that the way to have MIPS work for you is by creating the workflows to start. And when you do that, the work will become easier, the whole staff will understand, and you will get the scores that you are anticipating. Drive compliance by communicating to your entire staff That's really important, goes in line with the last one that I have. So the real thing that you really want to make sure is that everybody's bought in. Everybody has a buy-in, whether it is holding them accountable to do their jobs and really get this information. You can't leave it all up to an executive that's in charge of it, nor can you leave it up to an individual provider and say that it is their sole responsibility to get all of the answers that you need for MIPS. Have frequent check-ins, especially early in the year, to understand where you are and to give yourself the flexibility to allow for adjustments in your workflow. So focusing on the cost category is really important this year, and learning what steps you can take right now to help your score. This year it's going to be 20%, but it's going to move up to 30% next year, and that is a big chunk. If you think about the fact that if you score a 0 in cost next year, you will be in the penalty range, considering you need to have above 74 to get out of the penalty. And prepare to get the best 90 consecutive days for promoting interoperability. Don't wait until the end of the year to try to figure out what your best 90 days were. Learn about it now. Put extra pressure to do really well. Over the summer, if you're slower, or when kids go back to school, if you're busier and you can't do these type of things, make sure you get it done now. We're headed into the summer now, and if your population drops, this might make it a little easier to get some of this stuff done now rather than the fourth quarter. So a little bit about benchmarks and 2021 benchmarks. You can see here, CMS creates benchmarks utilizing historical data. So they're going to use that from 2 years prior, and it also is going to be from submitted data for that performance year. So in 2021, benchmarks were created based on the 2019 performance data. Each collection type has its own benchmarks, even for the same measure. As you can see over on the right-hand side, for instance, with measures number 128 and 134, you can see this first line here shows you the Medicare Part B claims if you were to report through them, and saying that you really max out on your decile 5 by getting it 100%. And then you have the second line, which shows you the MIPS CQMs. So a CQM is what's reported directly through to, what is reported directly through a registry, just like MIPSPRO. And then you have ECQMs, and this is what is called end-to-end reporting. And this you could report directly through your EMR or through a registry, just like MIPSPRO, where we can get you the extra points for some of these measures. And as you can see, the benefit of that is that it doesn't top out right away, that you have a little bit more of a curve in the information. So as I said, we can do the ECQMs here at MIPSPRO. If you talk to anybody on my team, they can help you understand how that can happen directly from your EHR. There are a couple measures that there won't be benchmarks provided prior to the close of the year. So for right now, for these measures, for these measures, 226, which is the smoking, as well as some of these other ones, they had so many significant changes in the measure that they cannot have a benchmark from a previous year. So the benchmarks will be figured out at the end of the year. Four details to consider when choosing measures. Choose measures that fit into your specialty. Choose measures that have smaller denominators. Look for measures that are not topped out, and find extra high priority outcome measures. And we're going to go into each one of these categories as we move through the next few slides. So choosing measures that fit into your specialty. You can check here on our page for measure recommendations at MIPSPRO.com. We have the quality measure recommendations by specialty in here. Also, if you're interested, we do have qualified clinical data registries. We have which provide specialty measures for certain areas and certain specialties. We work with mental and behavioral health through our MBHR associated with the APA. We have PT, OT, and orthopedic measures, as well as audiology measures that are new for 2021. And then we also have an emergency medicine, hospitalist, and anesthesiology measures that is a new product for MIPS. So if that is something that interests you, once again, you could reach out through us through our webpage, or I'll provide my contact information at the end of this call. Choosing measures that have smaller denominations. So broad measures like smoking, your alcohol, flu, medications, they have large denominators and are often harder to score well on. So you only need to have 20 eligible patients, right? So you need to have 20. So instead of reporting a measure that has 5,000 patients in the numerator, in the denominator, find one that has 100, and that can make your workflow much more less burdensome. Smaller denominators make it easier to control the outcome as well, and are normally specialty specific, as well as they reduce the reporting burden. So a measure like 130, documentation of current medications, this has all patients 18 and over, each denominator eligible visit, no diagnosis is associated with it, and you need 99% plus, I think it's 99.5 to be honest, to get 7 points in a registry reporting. So choose a measure, not saying that everybody on this call can choose this measure, but screening for osteoporosis for women age 65 to 85 years of age. This really narrows down the scope of this measure to only females 65 to 85. It only needs to be asked once per performance period. It is not diagnosed, as long as they don't have a diagnosis for osteoporosis on the data they encounter. And you only need to get 51% to get 7 points with registry reporting in 2021. So more measures like number 39 can help you get a better score, have less impact on your daily workflow if they match into the specialty that you work with than it is for, we understand, measure number 130, it's an easy measure. It's supposed to be an easy measure. A lot of people miss out on some of the parts of it, but it's supposed to be an easy measure, something that is involved in what you're doing every day, but it's really hard to be perfect on that measure. So look for measures that are not topped out. So here are the measures that, and explaining a little bit about what topped out measures are. There are two different types of topped out measures. We have topped out at 10 points, right? You need to have 100% to get the 10 points. Capped at 7 points means that you cannot get more than 7 points for those measures. Median performance score is 95% or higher. Performance is so high and unvarying that meaningful distinctions and improvement in performance can no longer be made. And after 3 years of being topped out, a measure may be removed in the 4th year. So for measures that are extremely topped out, 98th to 100th percentile, CMS can remove the measures prior to the end of the 4th year. So a couple of the popular topped out measures on the right-hand side, you'll see here heart failure, that is capped at 7, but a measure like the Falls Plan of Care, you can get the 10, but you need to be at a perfect score to get there. Find extra high priority and outcome measures. Bonus points will not be awarded for the first mandatory outcome or high priority measure. However, 2 bonus points will be awarded for every additional outcome measure, and 1 bonus point will be awarded for every additional high priority measure. So what you're looking at here is the ability to report more than 6 measures. When you do more than 6 measures, it gives you the opportunity for bonus points. So if there are outcome measures that you're interested in at least testing out for the year and maybe instituting in your practice in 2022, you might not have great scores with it, but if it falls outside of your top 6, you can get bonus points. There are over 54 outcome measures as part of registries and 123 high priority measures. So there are measures to be able to do this with. Measures must meet the 70% completion rate to be eligible for bonus points. I see a question about reporting data. You need to report on 70% or more, and that started in 2020 and moving forward in 2021 at 70%. Also, with that 70%, CMS does not want you to cherry pick your best 70%. They want you to report as much data as possible, and cherry picking is not looked at very favorably in CMS nor during an audit. Measures must meet the 20 patient case minimum and have at least one patient in the numerator to be eligible for those bonus points. Any outcome or high priority measure beyond your top 6 measures will not receive an achievement bonus, and bonus points are capped at 10% of the maximum achievement points. So what quality measures are being removed? As you can see here, finalized measures for 2021. There are a number of measures that are being removed from the year. Not terribly a lot of popular measures. However, there is a number of opioid measures, as you can see, 408 through 414, that are being taken out. And that was probably the most important when you're taking a look at this. Finalized quality measure changes in 2021. As you can see, this list is pretty extensive. They range anything from a very small change in the denominator. Maybe they added a couple of denominator eligible visit types, change some of the things to give you different credit and so forth. So you could take a look at our page on MIPSPRO.com under the measures and really take a look at what the changes were for 2021 so you could be ready for any of those changes. I think the major change that I saw was for the alcohol question, and that is 431, and that is changing to look very similar to the smoking question, where it's going to have 3 different parts to the question for you to get credit for it. Improvement activities. I highly recommend, if you do not do improvement activities, to get a jump start on that this year. It is a free 15 points. You do not want to miss out on this opportunity. There's 100 or so different activities. Small groups need to do 2 medium or 1 high weighted activity, and larger groups need to do 2 high weighted activities, 4 medium weighted activities, or a mixture to get to that. So this is free 15 points, going to be necessary this year for you to make sure that you're above that 60% threshold, and also give you the opportunity to get into that 85%. They're modifying 2 small, 2 parts of 2 of the measures, as well as they removed 1 activity based on the program expiring, and then they did finalize the adoption of the COVID-19 clinical trial measure. So an important part of what you need to know is knowing what categories you need to report for. So we're going to first start, almost everybody needs to report on quality. Almost everybody needs to report on improvement activities. It's very difficult to get to be exempted from those. You may be able to get exceptions, but to be exempt from those measures is unlikely. But do you need to report promoting interoperability? So first off, there are a number of clinicians, right, that are automatically out, that do not need to report of it as individuals. If they are part of a group with multiple specialties, and some of the specialties need to report it and some don't, they need to report if they're reporting as a group. But if they are reporting as individuals or groups, for instance, of psychologists, do not need to report promoting interoperability. Also nurse practitioners, therapists, and your non-patient facing providers like your some radiologists, pathologists, and so forth. There are also some providers that can apply for an exemption. So to be exempt from promoting interoperability, small practices of 15 or less or fewer, I'll use proper English, or fewer eligible clinicians, they can go onto the QPP website and take the exemption for these for the promoting interoperability. However, it's not 100% guarantee if they will approve you for it, but most of my smaller practices do go for this if they don't plan on reporting promoting interoperability. If you use a decertified EHR, then you can go for the exemption, as well as the extreme and uncontrollable circumstances. exemption. So for those that are not exempt from it, promoting interoperability has a number of changes that you want to make sure you pay attention to. The query of prescription drug monitoring, your PDMP, bonus increases from 5 to 10 points and will remain an optional measure. The introduction of a new optional measure, health information exchange bidirectional exchange measure, that's coming out this year, as well as a measure name change. So it was support electronic referral loops by receiving and incorporating health information. They made a change to it so that you're not just receiving and incorporating, that you are reconciling. They want to make sure that you are looking at it and doing the work that's needed. MIPS 2021 promoting interoperability. Here is the overall scoring methodology, very similar to what it's been for the last couple of years, but I put it in here so that you can make sure that you have it. And just remember, the security risk analysis is important. It is not point worthy, but you will get a 0 in promoting interoperability unless you click the button saying that you did a security risk analysis. And from what I'm told with some of our consultants that work with us, that it is something that people are failing, and if they cannot produce their security risk analysis, their score will be adjusted. So know what categories you need to report. Next one is the cost category. So there are minimum thresholds for every measure. The TPCC, which we'll get into in a minute, is 20 patients, MSPB 35 episodes, and then there's episode-based measures that range from 10 to 20 points. There is no reporting necessary for this. If you do not qualify for any of the measures, you will be automatically excluded, and with an automatic exclusion, it will move into your cost category, your quality category, those 20 points. So as you can see, it is moving to 30% for 2022. Currently, it is at 20%, and this is showing the difference between cost and quality scoring. So who needs to worry about the cost category? So the TPCC, or the total per capita cost, had a lot of changes. Actually, most of them were made in 2020. However, a lot of providers who were eligible in 2019 became not eligible or ineligible for measures moving forward for TPCC. So it's updated to limit the attribution based on E&M and other primary care services. So the providers in these specialties are the ones that will come across total per capita cost, and could be, if they fit into those denominator minimum patients, will get attributed a total per capita cost score. For the MSPB, which is the medical spending per beneficiary, medical episodes are attributed to any TIN rendering at least 30% of the E&M services during the index submission, and to any clinician who bills at least one E&M service that was used to determine the episode's attribution to clinical group. What the important part about this to understand is that a TIN, and for all of cost scoring, it is TIN related. So if your entire group meets the minimum, then you will be attributed with each one of these scores. So keep that in mind. It is not an individual measure. If you're an individual, you're your whole group in this scenario, but everybody within the TIN will receive the same score for cost. And lastly, who needs to worry about the cost category? We're going to go over the episode measures. So the episode measures are more specialty specific. You'll see this list is a bit longer than the TPCC list. This goes into all of the different measures. If you have questions and your specialty shows up here, you could give us a call here and we can walk you through what measures you will be associated with in the cost category, and really hone in on how we can help you attack and do better with these measures. Another MIPS tips and tricks here: reporting as a group and individual at the same time. So this is another area that you could do through a MIPSPRO platform. So in this scenario that you see below, the group score is 89, and it's a fairly decent sized group of 20 providers. So if they were to report individually, each provider gets their own score. Some will be below 89 and some will be above 89. It's hard to meet the 20 patient minimum for some measures. So those measures, when you group report, can help you meet the minimum for some of the tougher measures that don't have large denominators. And you cannot take advantage of patients seeing multiple providers. However, in the next group is the group scoring. Everyone in the group will receive that 89. You get pulled down by your lower score, so those that are not performing up to the standard will hurt your score. And it has issues with providers not carrying their own weight. You could have one or two providers that really drag down your score for certain measures. So optimally, reporting as both, you will report two measures to CMS through our system. So for those two measures, what you will see is that when you report both, every provider will get their highest score. So providers that score better than 89 will get their individual score. Providers that score less than 89 will get their group score without hurting the group score. So everybody will get a minimum of the 89. You could take advantage of the 20 patient minimums. You could take advantage of the specialty providers within your group that may do well under certain measure categories, and you really take advantage of those top performers. So how do you get to 60 points this year? Remember, there is no easy way out this year. So if you're taking a look at this information here, you have your insights. Scoring 50% in each category is the way to do it, and 100% in an IA is the key, no matter what categories you are exempt from. So under no exemptions, if you need to get, you would need to get these points here, so 20 in quality, at least 50% in promoting interoperability, the full points in improvement activities, and at least half the cost, plus half the complex bonus will get you to your 60 points to avoid the penalty. So when you take cost out of the scenario, it is the exact same thing. Everything gets moved over into quality. You still need to get a 50% score in quality. You need to get 50% in promoting interoperability and so forth. So the cost and the complex bonus, you have much less ability to determine your score than you do with the quality, promoting interoperability and improvement activities. So to bank on the fact that you'll get 50% is not the greatest thing to do. So you want to be able to have the ability to get you want to have the ability to get your scores above this 50% threshold, so you're not too concerned about the cost and complex patient bonuses. So some other tips and tricks, starting now, start tracking each MIPS category now. Obviously, starting on January 1st would have been key and optimal, but April is not the worst time to get started. Get your 90 days for PI and IA over with so you can concentrate more on quality and cost moving forward. You can utilize a program like MIPSPRO that can provide quality measures benchmarks early in the year. Design workflows to maximize data capture. Providers limit burden and increase time spent with patients. Staff limit errors and drive compliance. You want to make sure that everybody is bought in, and that's very important. And I see it a lot of times where certain providers might not be bought in, and it hurts the team score or it hurts the overall not excitement, but energy around the program to make sure that you are performing well. Focus on performance improvement by attacking gaps in care. Providers, see if someone is not carrying their own weight. With the patient, see if there is a patient type that is causing your scores to suffer. Do you have diabetic patients that are hurting your scores on some of the diabetes measures? Are your smokers that are not getting counseled, are they hurting your smoking measure scores and so forth? See what measures that may have been overlooked. So take a look at maybe some of the measures that you might be 5 over 5 at this point of the year, but you can really maximize your score by having 20 patients fill into the denominator. Track more than 6 quality measures, choose 8 to 10 measures and watch their performance. That I always find is key. You have the opportunity to add the extra measures for both outcome measures and high priority, giving you extra points at the end of the year, as well as not limiting yourself if there are issues in performance for some of the measures that you might have started out. So never start with a minimum of 6. 2021 scoring hierarchy, TINs and MPIs sometimes could have more than one final score. So over here on the right-hand side, you'll see a comparison of what it looked like from the 2020 score to the 2021. For 2020, the highest APM score was first. Then the second one was the APM entity final score, then your virtual group final score, and finally the highest of your group or individual scores based upon where you would end up. So if you had all 4 of these types or 5 types of scoring, you will get the highest APM score will be your score. For 2021, it switched a little. If you're part of a virtual group and you get a final score, that will be your score in 2021. Otherwise, any of these that you see over here, 1, 2, and 4, will be your high score, will be your score, whichever one is the highest. So a little change in that. If you have multiple ways that you are reporting through, you could work with us and our consultants to make sure that we are optimizing that. 2021's the APM performance pathway. This was introduced to the APP for 2021. So if you're part of a MIPS APM, you have multiple ways now to report. There's 2 collection types other than the CMS web interface. So we have the ability to report through the APP through CQMs and eCQMs. So that's reporting option number 1. This is brand new for the year. Then we have the APP web interface, which has been around for a number of years. That's how ACOs have reported. They will, this is expiring at the end of 2021. So this is the last year you'll be able to report as an ACO for 2021. The big differences in the reporting are going to be the quality measures that are needed reported. There are 10 self-reported measures in the web interface, and there are only 3 in the self-reported measures. However, the big change the other way is that in the reporting for the APP, CQM, eCQMs, you need to report on 70% of all of your patients, Medicare and other patients, exactly like MIPS reporting, compared to the 248 patients from ACOs that you needed to report on previously. Promoting interoperability are going to be the standard same measures. Improvement activities will give you an automatic score of 100, and cost is taken out of reporting because they are already cost attributed. So the new collection types are anticipated to reduce the reporting burden for its providers. 6 standard quality measures focused on population health. You have the CAPS for MIPS survey, diabetes, hemoglobin A1C, screening for depression and follow-up plan. I will tell everybody the follow-up plan must be in there. If you're screening for depression and they have depression, you need to have the follow-up plan. I see that as a miss a lot. Controlling high blood pressure, all-cause unplanned readmissions, and all-cause unplanned admissions are claims-based measures that are done through your claims. So with the APP performance pathway that we were just sharing in 2021, I showed this a little earlier, but to separate it, the cost score is going to continue to be rated at 0% since they already are part of costs. And you get the automatic 100% score for improvement activities, which is 20% of your score. And then the promoting interoperability will be scored as individuals or as groups. So it's really this 50% here that you get for quality. And once you get that working for you with the new performance and the new ways to do things moving forward, that's the way to really achieve high scores, is through your quality scoring in the APP. If you have questions about the APP and APM performance pathways, we have a number of experts here on staff that can help you walk through how you are reporting, what you need to report on, and so forth. So the MIPS value pathway framework, it was originally supposed to come out this year in 2021. It was pushed back to 2022 under the proposed rule. That is to move towards an aligned set of measures, and they do believe that it's going to be a little bit of a slow release as they are making a number of changes and want people to adopt the new way of reporting. So the foundation under these programs is promoting interoperability, the population health measures, enhanced performance feedback, and patient-reported outcomes. And on top of that, you'll see cost, quality, and improvement activities. So what's that going to do for you? Specialty providers will have measures that reflect their scope of work, meaning that if you are an oncologist and you're doing the MVP for oncology, your quality, your cost, and your improvement activities will all really closely align under your specialty. This is where I've warned for a number of years now that if you're a specialty that does not have a cost score, that is probably coming soon, and the MVPs is probably the way they are going to do it. More providers will be eligible for the cost score, as I just said, and the reduce the burden and drive impactful care. Really comes down to measures that make sense for a specialty instead of a GI doctor asking a question about melanoma. It really goes into how you as a specialist are treating that patient rather than asking questions that have nothing to do with your specialty. So determine your strategy and your reporting methods. Why a registry? Maximize your ROI, gives you real opportunity to dig down into your data more than the other options that are out there. Take a look at what's going on for your reporting, and maximizing your return on investment really gives you the opportunity to understand what your score is throughout the year, change your workflows throughout the year to really create the opportunity to maximize your incentive. More measures. A registry like MIPSPRO has over 200 measures, gives you better options for your specialty, allows you to pick the measures in which you score best in. Deal with the experts. I know you can work with your EHR, you can work with CMS through claims and so forth, but we understand MIPS from the beginning to the end, so you will have the ability to work with MIPS experts as they help you navigate through all the changes and obstacles. Combine data from multiple EHRs and practice management systems. We try to pull data from all over the place to help maximize your score and bring in the real information of what your providers are actually doing in the rooms with the patient. Track data all year long to allow for performance improvement. Eligible for the end-to-end bonus and report on ECQMs. And dig into your data and attack those gaps in care. We have some gaps in care pages that are available for you to really give you a buy-in on how to maximize your MIPS score. MIPSPRO offers live dashboards, drill down capabilities that help identify gaps in care. As you can see, here is our dashboard and what it looks like with all of the measures. Easy to navigate dashboard is designed strategically for administrators to understand, track, and drive performance improvement, leading to better scores, higher reimbursements, and improved patient outcomes. What you're looking at here is a drill down of what it looks like for patients with measure number 48 as not met, so that you can go in and take a look at those patients and find out why they are not met and how you can move forward to take a better opportunity, especially if you're looking at that in the first or second quarter to score well. So our best-in-class US-based support and integration teams, reducing the burden of quality reporting, allowing you to do what you do best and provide the highest quality of healthcare to your patients. We have a very large group of partners that we work with that are here to help you across the entire spectrum of value-based care. And you can reach out to us to ask any questions about how we can help you, working with our consultants, working with our other programs to make sure we maximize your value-based care. So how do you track costs? Introducing MIPS Cost Analytics. So the first and only technology platform that provides current year payment data for all Medicare patients. How MIPS cost analytics helps with MIPS. We show estimated MIPS cost score throughout the year. We can't give an exact number because MIPS cost scores come out at the end of the year based upon every patient in the Medicare system and how it works. Gives actionable insight into each cost measure, provides you anticipated attributed patients and episodes, provides individual patient HCC scores, allows you to easily identify those patients and providers that have the largest impact on your cost score. And data is very important to this, understanding that data and being able to work with that data to maximize your ability to score well on the cost and take care of your patients. The information shared with this program really allows you to take a look at comorbidities and other things that your patients are going through and paying for through the Medicare program that allows you to treat them even at a higher standard than you currently are. MIPS cost analytics, this is just a sneak peek of what it looks like, one of our scorecards showing an individual patient history and what their costs are and so forth. This screen is available with our MIPS cost analytics. If you have questions, you can visit the site that you see here on the right, or just go to our HealthMonics site and click on our MIPS cost analytics section. So don't miss our next April webinar. We are doing a webinar on interoperability, the truth behind the MIPS curtain. So that's Thursday, April 22nd at 2 o'clock. And also stay tuned for our May 2020 webinars that we will be getting out at the end of this month. Feel free to ask any questions at the contact information below. To sign up, you can visit MIPSPRO.com or give us a call. And we can help you. So thank you very much. I'm going to take a look at the questions. I have a couple minutes that I could go over some questions. Otherwise, I will get back to everybody with your answers. So let me check out what I have. So the first question is physical therapists are still only report quality and improvement activities as long as they are an individual or that everybody in their group fits that physical therapy or occupational therapy category. That is correct. You will only need to report on quality and improvement activities. Getting rid of the benchmarks. So why did they get rid of the benchmarks on some of the popular categories? Mostly because they changed the measures significantly. It is anticipated that there's still going to be plenty of providers that are going to report those measures. So the benchmarks will be back, but it is not 100% guarantee. But they will put the benchmarks in for those after the year is over. A question here about MIPSPRO's capabilities of extrapolating, quantifying, and reporting on measures that are not supported by the EHR. Yes, we can do some things with that, not all. It matters what your EHR is and how we integrate with it. But if you contact our strategic partnership manager, Philip Spence, he'll be able to work with you to make sure that we're able to do what you want. Question about registry submissions and don't we only need to report on 60% of the data? It is 70% this year, and once again, they do not want you cherry picking. You will get a copy of the slide deck as well as a copy of the video sent to you shortly after this presentation. The MVPs with multi-specialty clinics, that is another question here. I'll have to get back to you on exactly what the plan is for that. They haven't really come out 100% with one, but I believe that our team was on a registry call just yesterday and the day before that they went over that on. So I will get back to you on that question. There is a question here for behavioral health measures and my recommendation. We have a website, MDHregistry.com. Sorry, MDHregistry.com. If you go there, we have a list of measures that we worked with the APA to create just for you. Sure, there was another question specific about MIPSPRO and what is the difference between not met versus incomplete in the patient details. Not met would mean that you have the answer of the coding or the answer saying, no, I didn't ask that question. Incomplete would mean that there's nothing there. There's no, yes, I did it, no, I didn't do it in the system. How do we find out what measures are topped out? The measures that are topped out, if you go to our webpage currently and you go to the MIPS measures section and click on the 2021 MIPS measures, up at the top, there is a link to all topped out measures for CQMs and ECQMs as well as claims. And okay, so that's about it. I'm gonna let everyone go about 5 minutes early. I appreciate your time today. If you have further questions, I will be around to answer them throughout the day and into next week. Actually, I'll be around for a while, so you can ask any questions anytime. So thank you very much for participating in this webinar. I appreciate everybody here, and I look forward to working with everybody in the future. Have a wonderful day and a great weekend. Thank you.